Welcome to TCN Talks. The goal of our podcast is to provide concise and relevant information for busy hospice and palliative care leaders and staff. We understand your busy schedules and believe that brevity signals respect. And now, here's our host, Chris Como.
Welcome to TCN Talks. Our guest today is Dr. Katy Lanz. In fact, it's great to have Katy back. We had her on last year. She's the founder and principal of TopSight Partners. Welcome, Katy. Good to have you.
I'm glad to be here again. Thank you for having me.
Well, Katy, what does our audience need to know about you?
I think just that I myself am in transition. This is a fun thing to talk about. I think because the industry is in transition as well. We all have to evolve through this, and I think that's where the creativity and fun comes. So I'm taking some time, even at my advisory work, to really think through and interview as many people as possible to find out what's happening out there. And so what do they need to know about me? A little context. You know, I introduced myself in the last one, but quickly, I'm a geriatric and palliative nurse practitioner who got my founding roots in North Carolina when I was working with a not-for-profit hospice for about a decade, and ended up getting my nurse practitioner degree and helping them and the local systems think through palliative care and how we help people avoid unwanted and unnecessary things. And that kind of led to my journey into more education and to do some of the demonstrations that have occurred over the last 15 years. So I left the bedside almost I'd say about 14 years ago now, and have been really focused on value-based care ever since, and looking at the broad continuum of innovation in that context, but always for the frail, seriously ill. That's my heart. Yeah.
And that's actually what I love about you, Katy. I was actually talking to a CEO I have immense respect for, and they were talking about one of the podcasts that we just had, was just released actually, from another well-known consultant. And she asked me this question. She goes, "Is there not a consultant in this space who's been by the bedside?" I said, "Oh yes, Katy Lanz." And so they were like, "Well, I can't wait to listen to this show that you're going to have with Katy, because I think it gives you a different perspective, and it gets you a lot more cred because you've been by the bedside. You've held the hands of dying patients. You know what it's like. You know the clinical aspects. You know what it's like to be an IDG team member. You've also been in the innovation of palliative care." And so I just think that gives you such a unique perspective. And what I love about you is when I'm around you, you always shift my perspective of something I'm been wrestling with. And so you and I are walking by Home Care 100. I swear it wasn't maybe a 5-minute conversation. And I'm like, "Hey, Katy, I want to have you on my podcast." And this was my original thought of the show. And just in a small conversation, you shifted my perspective. And so the original idea was, "Hey, Katy, I think if we did a show on the flight of substitution competition." So, Katy, you come to Asheville, you go to all these wonderful breweries, and you get a flight of beers, right? You get a sample of all these different types of beers. And I thought a flight of substitution competitions would be helpful to hospice leaders. And here's why. I've heard recently that this person was talking about a lion tamer uses a chair to tame a lion because the 4 legs of the chair literally paralyze the lion. And my concern for hospice leaders is there's so much stuff coming at us. We're like that lion, we're just paralyzed. Like if you go to Home Care 100, you're paralyzed like, oh my God, there's all these things coming. And so my original framing of substitution competitions, I thought, hey, here's kind of the flavors. And I'm just going to say it out loud because then I'm going to quickly get to, and Katy shifted my perspective in a small conversation. So the flavors I thought they're out there are like ACO aggregators, value-based MCOs. There are payviders. There's health tech, fintech. There's equity-backed portfolios. There's network building. There's post-acute provider service expansion. Then there's emerging primary palliative care type models. And when I first even talked to Katy, she's like, well, those aren't exactly mutually exclusive because there's a lot of overlap even amongst those kind of flavors or flights, if you will. But this is what I love about Katy. In a couple of questions, I can't remember how you said it, I could feel my mind shifting from the term substitution competition to much more like, wait a minute, these are collaboration opportunities. And why am I even framing this as substitution competition? So, Katy, I want you to take it from there. There is a lot headed our way. And so and when you and I were doing show prep, you start to share this beautiful picture with me that we're going to actually put in the actual summary. And I think this picture really gives a current reality, but a futuristic reality of where the serious illness space is headed. Can you describe that to our listeners and kind of take it from there?
Yeah, absolutely. And thank you for all the nice things that you said too. The feelings, mutual. And I hope that others shift my thinking. The way I think about it and the things that you just described as substitution competition, in my mind, are business structures, potentially payment structures for services. And they aren't necessarily services that are defined yet, right? They are services that anyone can build. It's happening more readily in the private world that there's some innovation being built. But let's be honest, even over the course of the last, 15 years and 20 years, I would say, since the for-profit integration into the hospice world, we've seen even hospital systems create new products, services that are potentially duplicative to some of the things that we have historically built in our industry. And I don't think it's necessarily substitution. Anyone can build new models of care. And in my opinion, it becomes like a super creative time to either collaborate, build, buy, or partner, right? Because now we have new payment structures to work within to build things. And so what you described as substitution competition, I think of, in my mind, business models to support products that i.e. the workforce that does this work. I'm a nurse at heart, nurse practitioner, that we can build to actually meet the needs of the patients that we serve. And so if you look at that diagram that I shared with you, I think about what used to be, and we have these episodes. If you look at the left axis, this is function and health. And for those that know me, I've been kind of, I'd say, evolving this picture for some time, but we have a traditional juncture of care, critical junctures, and a person's life as they're dealing with serious illness. And you see over time that they have these episodic critical points where they have a crisis. They go into the hospital, potentially they go to the ER, they might get home health services, they might get hospice, they might have, I would say even skilled care, but they're time limited. And that time limitation is becoming more and more governed. It's the utilization management that we hear about. It's more and more defined, and it's not a forever episode. And unfortunately, when we discharge patients, the clinicians, we know that patient's going to get sick and go right back into the hospital. And as you enter this new value-based kind of care world, we shift to the right and we think about the patient's experience over time, function and health on the left, again, time in the last 2 to 3 years on the right. And I just think as a clinician, what do people need? Let's say, Chris, you get sick. I'm going to give you a disease. What do you want to have? Let's give you, let's give you COPD. Okay. You and your wife and your kids are going to have to make some decisions about the type of care that you get. And in the left side, these are benefits and services that are paid for in a fee-for-service way. But what you really want is something creative that meets your needs when you need it. You want a practitioner and perhaps even a social worker or a guide to help stay with you the whole way through your illness. You don't want to have to let go of them for some service or elect something and let go of something. I think that, what we really need as we get sicker, we need the things that are in the boxes down below. We need care navigation and support, really good assessments that are not just focused on what we can do and our functional, nutritional, cognitive status. They're like focused on who we are as individuals and what we want. Because I got to tell you, not everybody wants to go into the hospital once they get a disease like this, and not everybody wants to be in a skilled community. And so with good planning, you might be able to avoid that and integrate things like geriatric crisis care. And that doesn't mean geriatric doctors even. It could be paramedics coupled with nurses that are doing, and even enabling home health kind of skilled needs like IVs and even breathing support for you with COPD when you need it so that you don't have to go into the ER. And as you get sicker and your condition changes, you might need personal care and even intensive palliative care, where people really know how to manage your symptoms. They know how to manage your disease. They know how to keep you as comfortable as possible and as strong as possible for as long as possible in your home. So I believe that it's not necessary what we're seeing in the new products coming through, and I'm calling them products instead of substitution competition because they could be built by the home health and hospice industry in partnership with some of the at-risk, we'll talk about that in a minute, entities, or just health systems that need support and or people direct to consumers, public that need support. I mean, think about if you could go on Amazon and find the colored, boxes down below and see who's best in class at that and who's in your area and how much, what you get for what you pay for. So I just think that we're shifting. The way that we're paid for is going to change the way we deliver services. And I'm actually glad for that because not everybody needs everything that home health offers or everything that hospice offers. It should be dose escalated based off of what you need, Chris, with your COPD as you decline at home with your family. And I'm sorry, I just gave you a terminal diagnosis.
Well, actually, you don't know this, but actually, as soon as you and I are done, actually, I've got to go to a funeral. And so what you said is actually just really close and near and dear because we just saw a dear family member go through a situation that ended up they passed away yesterday. And there's so much in what you're saying, and that we're definitely going to include that picture, Katy, when we actually put it out. And so your blue oval, can you just talk about that a little bit more? Because that blue oval feels like that is where the creative space, that's where the opportunity is, because the old picture is just here are these silos, right? And people throwing people over, and there's a lot of white space in between the silos, but the blue oval kind of paints the picture of a different, and I love that you actually use blue, by the way. Do you know like the whole book, Blue Ocean? There's like
I don't, but it's my favorite color. If you can't tell by the paint on my wall and my jacket and everything.
well,
Yeah.
there's a whole world of wisdom out there of that. Like, the blue ocean is like the world of possibilities. The red ocean is where the sharks are kind of fighting over what was. The blue ocean is what could be possible.
Well, the blue, it happens to be my favorite part of this continuum because if you think about let's think about any disease, any chronic disease. When you get this diagnosis, your doctor's talking to you about it, they're talking about treatment. Or upstream, we're saying maybe 3 to 5 years upstream, there are decisions that people are worried about. They don't really know what this means to them. They don't really have somebody involved in their life. And I see the blue as potentially primary care coupled with really great social support. And those products could be built, they aren't mutually exclusive. They could be built separated, but I don't think they could be living in silos. They really should be connected. The primary care of the patient with this should be supported by something in the blue box. And that is the engagement, meaning, continuous connection with families, really great social determinant assessments, and not just assessments. I hate just the word assessment because all that does is like ask people questions. What are you going to do about it? So navigation support services, what's available to you in your market, what's in your network, and then counseling as you make the decisions as you fluctuate up and down that continuum. And I also believe it can't be just a call center or just a standalone. It has to be supported with on-the-ground intervention. So 24/7 call support, yes, but then the capability to upfit someone to go out into the home as soon as possible to help support someone, because that's when the crises, can really take a downturn and you end up with unwanted, unnecessary things in the hospital. So the blue is that continuous person. Let's name them, I don't know, Susan. And Susan's your person, and you're going to call Susan and your PCP, and Susan works really closely with your PCP and shares all the information that she gets with them and in an integrated way. And Susan knows everything that's available to you in your market, and she's just your trusted person. And I'm making her a she because 85% of that workforce is women. Could be Paul too. We don't know. But I think that, this is a really important piece of the puzzle, and in my opinion, the jump ball. So if you're going to work with at-risk individuals and you want to create a network and you want to see who is the best quality, this particular group knows that, and they will be the ones likely making that coordinated care and referral. And so as you're building things out, being able to work upstream is the way that you assure that they're referred into your systems, products, and, I would even say traditional products like home health and hospice.
Mm-hmm. So maybe that gets to what I was going to ask you next, Katy, is people start to get their minds wrapped around this. And especially where you grew up, because most of our listeners are community-based, mission-focused, nonprofit hospices. What is your hope for them as community programs? Where would you like to see them grow up into the future or grow into what you're describing?
I think the cool thing about North Carolina, it is different in that it is a certificate of need area, and so a lot of times the traditional and historic programs are already partnered with the health system, already aligned with some ACOs and potentially at-risk, providers. So you have a step ahead of some of the states that are going to have to compete for these things. But what I would say to them is, I hope that they find a way to come together and highlight their capability to do the things that are needed in these boxes that I just described. And specifically for the homebound population, we don't need to compete. We really just need to showcase our value and build systems to support it. And so I know that that's going to require a lot of innovation. I know that it's going to require a lot of cash because to play in this now environment, you often have to come forward with the ability to support some of that downside risk. And together, there are some pretty deep pockets in these organizations, and I think we need to be aware of that foundational support that is to make really necessary products for the communities that we serve, the communities that have given us that funding. And in order to do so, we've got to adapt and we've got to think like entrepreneurs. And I would say, don't work alone. Mm-hmm. This is the most important time to come together and coalesce and build something brilliant. That's when Blue Cross Blue Shield and at-risk providers are going to look to you and say, we can't choose anything else. Let's say Team Health. They have doctors all over the state. Pearl Health. They need partners to support. They're going to need something that's a catch-all solution for every single environment that they have patients, every single zip code. So together we're better. And so I'd like to see people convening and really thinking about how we build these products together and go together to find ways to support the risk, or else, here's the bad part, we might have other people coming in with ad hoc products in each one of these categories that don't necessarily work within our systems and or refer to our systems. And we might find ourselves with decreasing census in our traditional products,
which will make
home health and
which will make it harder then for them not only to survive, much less be able to innovate into the areas that you're talking about. So as they think about who are their best potential collaborators, you kind of alluded to it, but when you think about collaborators in that whole blue space, Katy, kind of who do you think are the ones they need to be thinking about?
Well, there's incremental steps to get there. So if you are a person, you're like, gosh, it's hard to do business as is with our workforce shortages. We should at least acknowledge that change management it's really tough right now. People are burnt out. There's a lot of turnover. You want to take care of your employees. So to build new things or ask them to do new things can sound scary, right? My experience with that, having done that the last 15 years, is that the workforce is ready for it. They're actually burnt out because the old system's not working. Let's just say a home health nurse, and she's feeling like kind of checkboxy with her work, mm-hmm. and she is going in, and she's not allowed to continually do the things that her patients necessarily need because she's there to do a service and leave. And that doesn't feel good, right? We want to be able to provide services for our patients. That's part of our DNA. So I think that what that looks like is it doesn't need to be mutually exclusive that you do this or that, or that you build everything together. I would say it's a great time to test out new products. And or build together. And so there are products that are out there that are in the care navigation and virtual palliative care space that can, serve as an extension to you to reach out to people in your communities, and a vehicle to partner with that primary care and assure that you're doing and referring into the quality services that the patients are both eligible for and desire. So, I think it's shopping for those types of services. And there are, I would say, 2 or 3 companies that are doing it around the country they're doing a pretty good job.
So, Katy, it feels like as you kind of talk about then those potential collaborators, people are going to have to go through a thought process of, do I build, do I buy, or do I partner? Can you unpack that a little bit? In fact, the more that I keep bumping this in multiple podcasts, it feels like there's a tool to be developed like a decision tree. But can you just talk about like what should guide people to go, well, you know what, we should just build that, or you know what, we need to just go buy it from somewhere else, or maybe there's another interesting way to collaborate or partner with someone.
Thank you to our TCN Talks sponsor, Delta Care RX. Delta Care RX is also the title sponsor for our April and November 2024 Leadership Immersion courses. Delta Care RX is primarily known as a national hospice, PBM, and prescription mail order company. Delta Care RX is a premier vendor of TCN and provides not only pharmaceutical care, but also niche software innovations that save their customers time, stress, and money. Thank you, Delta Care RX, for all the great work you do in the end-of-life and serious illness care.
Yeah. So build it would be, to just foundationally build the services that we defined in that video. So like care navigation, virtual palliative care, social supports that report out, and then the tech that's required to report into the primary care partner systems that we're sharing information about what we glean from the patients and families and what their needs are. Geriatric crisis care, that could be a product with, paramedics, potentially social work, a lot of telemedicine, and pulling in the right services for that patient to be able to stay home, and the right expertise to help them stay at home. It could be, a renal doc, it could be behavioral support, it could be their primary care. Intensive palliative medicine, that's when somebody really needs the specialty and they need a practitioner that can help, when the cure is not necessarily an option and the patient's starting to choose to stay home and have more comfort, that extra level of support, which is both, we know is interdisciplinary, team support, and then, the personal care too. So each one of these, you need to assess your capabilities in-house, and then also what you can and can't do. Knowing that if you in-house this yourself, it might be more of a regional play for your region or a local market play versus something that you're a part of that's much bigger, that is going after larger support services, which are alone you could not do. It might be harder to get, for example, a contract with Pearl Health or Upstream or, some of the players in the market who are at risk if you go alone. But if you go with a group and you have something to offer them, then it's a lot easier. I think there's certain things that have to be done in person, and those are the ones that those they need to be thinking about build locally.
Okay.
Yeah.
Katy, I don't know if you find this, and I think it was IBM years ago that it was the not invented here syndrome. And so I find in healthcare, sometimes we suffer from that. Like there's only one option. I must go build it. And it's like a hubris behind it, like not invented here. It's not invented. Have you seen that yourself? And
I have. And part of it is just baked in our history as hospice providers. I'm just speaking to a majority of your audience here. And that is, just we go into the market, we build it. If there's a need, we figure it out and we own it. This is different. This is very different, especially with the M&A and activity and large at-risk contracts across the whole region. And when I say region, I mean like state or multiple states. So I think that part of it is also ego, and that's just, we could build that and yeah, you could, but what is the downstream impact of that? Let's really think about the market influence and what would happen in the event that you do that. Could you eventually be competing? So for example, if you wanted to own your own primary care, you might be competing with some of your primary care referral partners that are historically, referring to you. So you're biting the hand that potentially feeds you and taking patients away from them. So I think that you don't need to do both. You need to partner too and create solutions together, but really think about this is going to be messy. I'm not going to lie. This transition is going to be very hard, and it needs to be market specific based off of the demands that we're talking about. And, I think that it just has to be strategic in every single location.
Something that occurs to me, Katy, years ago, I was at what's now MPHI, but it was the National Hospice Work Group. And there was a book written called Zilch, and it was about how nonprofit people tend to make something out of nothing. And where I'm going with this is people are had by their habits, right? So our matriarchs who have created this amazing thing before there was a benefit, and then there is a benefit. And now there's this movement that's become an industry in many respects, but the habit has been, we invented. We took something out of nothing and made something, but we're at an interesting inflection point. And so it just occurred to me just listening to you. I think you nailed it in that we've got to think about this differently as we go forward. Doesn't mean you totally throw that habit out by the side, but you're going to have wisdom of build, buy, or partner. And it's not always build because that served us well in the past. It's not going to serve
Yeah.
us perfectly in the future.
I totally agree. And I would push everybody to say, how do we get involved in patients' lives as far upstream as possible and as sticky as possible, meaning a product that just like or a partnership that just is evergreen, that won't go away, because that will assure that whatever happens in healthcare, you're part of where that patient goes. You have a touch point early on that helps support the, kind of guide path where that person will go based off of their needs. So that part I really push people to partner on because it's beyond the walls of a county. It goes further than that. And our patients go further than that. And the people who own the risk largely, and if we just look at the data, which we've talked about before, retail owning primary care, I mean, these are massive companies. And it's not just health plans who are owning payviders, is what I would call them. There's retail doing this too in partnership. So if we want to be with them, we might need to think about how we, build in, kind of large collaborations that enable them to scale across massive systems and have a one, kind of easy button that fits all.
Well, Katy, let me kind of wrap us up with two kind of final questions. I mean, first off, you're so gifted. If you can wave a magic wand for the future of the serious illness space, what could and should it look like? I feel like you've been hitting it in pieces and parts. This is your opportunity to kind of, Katy waves the magic wand. This is what the future should look like.
At-risk healthcare, meaning, value-based care where people are held accountable for the quality and cost, is only going to grow. And I'm glad that it is, because it's not about doing more, it's about doing right. So I would say build things that do right by people. Don't just build around a product, a partner, really think about how you build things that are right for people. Like Chris, when I gave him the diagnosis, and that's going to include things that aren't necessarily, part of it is the things are traditional models of care, but part of it are those in-between spaces of connectivity to assure that people don't fall through the cracks, that their social needs are met, that we are doing lots of anticipatory, thinking, and that we're supporting patients based off of how they're doing, not the benefit and as it's defined. So my magic wand would be to think like entrepreneurs and find ways to convene and problem solve to catch that jump ball so that you can really define these products together. I also would say I'm hopeful that you start budgeting to protect some of the downside, because if you want to be taken seriously in this new model of care, you have to be able to tell a person, be a payvider, retail, primary care, that you're so good at taking care of people in the home that we're willing to pay 50% of that downside if you allow us to participate in your network. We want to be a good partner to you. We know you're already having to pay for this, so this is what we want. And so my magic wand is that through those business models, through these types of thinking, that these beautiful new products are born that will take great care of us based off what we need, not necessarily a benefit that's out there that might have too much or too little. Yeah.
Good deal, Katy. All right.
Yeah.
Final thoughts. Any final thoughts? Last time I framed it this way. I'm like, you've grown up by the bedside, and we actually have a lot of staff that listen to this, not just leaders. Final thoughts and words of wisdom from Katy.
I think last time I talked directly to the workforce, and I'd like to do that again. Don't necessarily rely on the executives in your organization to figure these things out. Share what you think might work. Partner with your chief financial officer or someone who really can economize your ideas. That's not a strength always of us. And know that you can build things you can build things as a clinician too, and ask for responsibility in those areas to test it. Now, how do you do that on top of your job as it already exists? I think you have to create space for it. And that is something that's challenging to do. But starting to ask questions, lean into people who are trying to figure these things out, companies who are creating solutions like this, and you'll be surprised and in awe of what you might find out there that is really working for people. And so I challenge you to find your leadership as clinicians. I challenge you to ask questions and to lean into the change that's happening instead of resisting it, because it's happening whether we like it or not. And as our patients don't like dying, there has to be different levels of acceptance of that when we're teaching them about it. So, healthcare as we knew it is also dying. And so it's time for us to step up and help be part of the creation instead of sitting back and letting it happen to us.
Wow. Well, and Katy is walking this walk. And so when she and I were walking at Home Care 100, she introduced me to someone that heard our last podcast who reached out to Katy, IDG team member, and had an idea. And now they're living that idea, their innovation that they saw. They're in a value-based contract and they're doing incredible work. And so I love what Katy just said. And that's what to me.
Yeah, I think, was it my friends at the Holdings Group?
Yes, exactly.
Yeah. Or Care Ally, one of the two. I was going to say they're both founded by IDT, members, but both social products, socially determined products that partner with primary care. And hospice.
Yeah. And share it with your leaders, because hopefully the organization, certainly I hope I work with, that your leaders would hear that. But in that case, these people were part of an organization that their leader, either they weren't interested or whatever. So they basically worked on it on their own, reached out to Katy, and now they have a thriving business doing some incredible work. And I think that bottom up kind of approach to innovation, the people who have been by the bedside, again, I think that's what gives you so much cred, Katy.
Oh, thank you. And I'm willing to talk to anybody who wants to talk about it, because we can figure things out together. There's lessons learned, isn't there?
Yep. And she's legitimate about that. So, all right. This is an addenda to TCN Talk. Katy and I recorded this originally on March the 1st, and here we are on March the 8th. Well, a big announcement came out. Katy, I think they were listening to us. And so on March the 4th, the afternoon, big announcement from CMMI that the VBID demonstration is basically being stopped at the end of this year. And so I definitely thought I've got to get Katy's thoughts on that. So Katy, what are your thoughts? What's going on here?
I think they were listening to us, and we were kind of, I think, proactive in saying, yeah, there's going to be something new happening here, but we don't know what. And then, okay, here's now the what. But I wouldn't pull out the champagne yet is kind of my feeling. I have taken a couple days to really let all this sink in and talk to some colleagues who are big thinkers, and even some colleagues around the Capitol about what is happening, what's going on. And so I feel like we can have a good discussion now about what the implications are of this for the industry and what might be happening next. Why not?
Yep, let's do it.
Let's do it.
You want to jump in then? So, I mean, is it worthwhile? I mean, it might be a little bit interesting to just go, why did they make that decision? So, because you probably got a little bit of information, but I do think the better part is, so what are the implications? Where do we go from here?
Yeah. Well, I mean, let's just look at what it was first, and then what could be, what it was. We know what VBID is, and anybody who's listening, can read about it. But generally, the numbers have been small, and the incentive for most of the participants has not been incredibly strong to participate and refer as many people. And so it's just not had as high of an uptake. It's been a very small demonstration. We haven't had as many patients as we would have liked to be in it. So that's just part of it. And I think that they've learned pretty quickly about the setup, how they might change some things. It also was derived during a time when there was a different group in office, at CMMI. Mm-hmm. And I think that there is definitely a difference in some of the models that came out during that time period, especially geared towards populations that the leaders like Brad Smith and Adam Bowler were used to managing. And that's,
mm-hmm.
The serious illness population. And so, and working with health plans and trying to figure that out. And so, I think that they knew that things weren't necessarily as successful as they were, but even if it doesn't break even, they've learned a lot of information about the workflows that need to be created, the quality and governance that needs to be input, and then how that they can integrate other hospices that might not have been involved, because most of the groups that were involved also own their own hospices.
So it sounds like, so there is probably a group of people going, whew, dodge that bullet, and we could just go back to the way things were before. That is not what I'm hearing from you at all. I almost feel like I'm hearing in the background, like, okay, they've got enough information, so what do you think's next?
Well, think about this. Remember when they pulled the SIP for a year when ACO REACH came out? There was a change in the office. And then they came back out, and now it's called ACO REACH. It's got more around access and more about inclusion. And they were also the constituents and applications. They didn't want to take as much on the privately vested side. They were looking more at community assets being given the ACO REACH contracts towards the future, or smaller practices that were owned independently or not funded by venture capital. That was just what I saw. And I was one of the participants through my work with PCMA, which was an independent and physician-owned practice, essentially. So I think we've already seen that. If we read the tea leaves there, I think it's going to be interesting to see what happens with the next election and how that impacts, what this looks like. I feel when they take something off the table like this, it's like, okay, we've learned what we need to learn. And now I think they're going to come out with something. And there's something we need to really talk about here. And you and I haven't even talked about this, and that is the direness of the Medicare Trust Fund and what that means in the coming years. And we've really got to look at that and think about it. And I think with this we've already seen the strategic refresh around, they want 100% of primary care in some accountable care organization or in some type of accountable care relationship. I believe we're going to see this offloading of the government managing patient decisions and benefits. And it kind of keeps them out of it. It puts the healthcare decision making back in the hands of healthcare. I'm not saying the hospice benefit is going to go away, but in a situation like this where they're preparing to offload a lot of that clinical ownership to plans and or companies or payviders or doctors groups who would manage it, I see the carve-in as happening again. I do. And if you just look at like ACO REACH, where you've got a serious illness population, right? And you've got some primary care people, let's say Bloom Healthcare, the highest performing group in ACO REACH. And look it up. They're incredible. The people who own it, they're amazing people. They're a group of geriatricians, and they said, we're going to apply for this. They were in the very first part of the serious illness portion of this, and they ended up building their own hospice. Because they really wanted to manage the appropriateness of those patients and making sure that they get what they need. And they've done very well with that in terms of lengths of stay, access to the right services when they need it. And in the event that they're not quite eligible for hospice, they've built programs to basically be that glue between them and the patients when they're a little bit sicker and have higher needs. So, in those circumstances where the trust fund is dwindling, we're seeing more and more payviders that are accountable for people all the way through. I see the carve-in happening. I do. Wow. Now, on the Medicare Advantage side, this is different today. Like, this is more about getting ACO REACH, is not a Medicare Advantage. This is straight Medicare. So Medicare Advantage, they are wanting to get people off of their books as soon as possible into hospice as soon as possible if they're high risk and high need, because that is a risk to them. So, in my opinion, that's not always a great thing and we talked about this earlier in the podcast. I just don't see, I think the government wants to get themselves out of that decision making.
Wow. Well, Katy, then just kind of prescription to people, because I feel like a lot of what you said in the original podcast is still applicable, but listening to you, people go, okay, then what do I do as community-based hospices? What's your recommendation?
Well, I want to recommend something too. And if there are any government people listening, I think
there might be.
Could
there
we
are some.
Please have a demonstration that allows hospices to apply, independently, and or create some relationships with some of these payviders and or health plans. specifically hospices that are not owned by the health plans and incented in a perverse way. Can we just have some governance and try some of that out? Something like a hospice SNP we talked about, or like a larger demo that supersedes VBID, that's bigger and better. Could we not allow the industry to enter in that way? That would be wonderful to see that, and allows them to put skin in the game on the downside of their care along with their primary care partners. Like, wouldn't that be cool? Okay. So that's there. So what does that mean for the hospices? The prescription, though, for them is like, prepare yourself. Make sure that you are saving money to be able to pay to play in this new era of healthcare. And I mean on the downside of your care, further upstream, proving that you are getting the right people to hospice at the right time with the right services. And in the event that that means a length of stay that's more like, 60 to 90 days on hospice, that you've got upstream products that are profitable and also are what people need as they're going through that transition of functional, nutritional, and cognitive decline pre-needing the hospice benefit. And make sure that you can report on how well you're doing there, because there's nothing CMMI likes better than people saying, we've already practiced this and here's the outcomes of what we've done in these areas. And here's partners and relationships that we've been building the last year in preparation for this. So for example, if there's a payvider or a health system that owns an ACO in your area, like thinking of ways that you can really work together to take care of patients pre-hospice and get them the right amount of hospice for the right amount of time.
Perfect, Katy. Well, Katy, thank you so much for coming back. And again, to all of our listeners, we appreciate this late breaking news. Well, to our listeners, I always like to listen with a quote that makes us think about what we were listening to today. And Katy came up with this one. It's actually from Mae Jemison. And it says, never be limited by other people's limited imaginations. Thanks, Katy. And thanks to our listeners for listening to TCN Talks.